All right, now let's discuss the apnea test. Baseline ABG. So what is an apnea test? So the patient's on the ventilator. All right, you're going to get a baseline ABG. You're going to pre-oxygenate the patient for 100 at 100 for 10 minutes. And you do want to do is this, so you're going to not extubate the patient, you're disconnect the patient from the ventilator. You want to have trained personnel there. You need to have a provider that can reconnect it. You want to also have respiratory therapy. You want to have people watching. You're watching for spontaneous respirations. And you will want to stick a catheter inside. It can be a catheter delivering oxygen. You want it above the carina. And so you're oxygenating the patient. And what you're looking for is the patient not having any spontaneous respirations for 8 to 10 minutes. And then the follow-up ABG, the PCO2 is going to be greater than 60 or an increase from 20 from that baseline. This is the baseline that you get, right? You're getting that baseline and you have a PCO2 greater than 60, say if it was a 40, or increase from 20 from the baseline. And let's talk about post-hypoxic myoclonus. Rapid, non-sustained jerking movements noted on exam. You can see these, they're kind of like this. You'll see these repetitive movements like this. You need to get an EEG to rule out seizure. This is where you see these patients who have unfortunately had prolonged CPR and they're still technically alive. You'll see these and the families will get confused because they think they're having seizures and why aren't you doing things to prevent it? Sometimes they can be so much that even if you have decided to give them sedation, they still can be present while sedation is there. You don't want to paralyze these patients. All you're doing is you're paralyzing, you're stopping the muscle movement. It's not really stopping the brain, the neuroactivity. All right, this is a 17-year-old is having trouble with simple conversations. That's your clinical vignette. And let's go to an unfair board question, which of the following is the most likely diagnosis? Mild cognitive improvement, major neurocognitive disorder, delirium, normal aging, or depression. This is a 74-year-old woman who's brought to the clinic by her daughter who reports over the past year her mother is becoming increasingly forgetful, misplacing objects, and repeating questions. She's able to manage her finances and medications independently, but her daughter notices sometimes she forgets recent conversations. On cognitive testing, her mini mental state examination scores 26 over 30. She is independent in all of her activities of daily living. What is her likely diagnosis? Mild cognitive improvement. Now let's go back and we'll briefly discuss the mini mental state exam. This exam of where is copyrighted. There's a MOCA exam which is not copyrighted, which can help us with this. So just a little information. Mild cognitive impairment is characterized by cognitive decline greater than expected for age and education, but not severe enough to interfere with independence and daily activities. This lady is able to carry out her activities of daily living. Is distinguished from dementia, which requires functional impairment. Delirium is acute and fluctuating delirium, and depression may cause cognitive symptoms, but it's not the primary issue here. We didn't have any discussions how she's sad or how that she had recently had a relative pass. So if we change this up, and she recently had her husband pass of 30 years of marriage, he recently passed, then what we would consider is having depression is the cause of our cognitive impairment. Normal aging does not typically involve objective cognitive deficits on testing. For college-age individuals, a mini mental state exam such as 27 or less may indicate cognitive impairment compared to a standard cutoff of 24. So this lady was 26. We didn't mention it, but she was college educated. So for college educated individuals, say this again, and mini mental status exam such as 26 or 27 or less may indicate a greater risk for cognitive dysfunction. But compared to a normal non-college educated, standard cutoff would be 24. A score lower than 26 may be potential indicator refer for comprehensive dementia evaluation. Neurocognitive disorders, mild neurocognitive disorder, aka mild cognitive impairment. Mild cognitive disorder does not affect day-to-day function. They may need to get stuff to help them through the day. They need to get reminders on a phone. All of us may have a mild cognitive impairment nowadays because a lot of us rely on electronic devices to help us get through the day. How many even remember any phone numbers anymore? So we've given ourselves mild cognitive impairment, Major neurocognitive improvement would be dementia. In the cognitive domains, this is the domains that we look at in dementia, which is memory and learning, language, executive functioning, social cognition, which is our behavior, and complex attention, and perceptual and motor movements. Now, let's talk about there can be what other things can cause this. We talked about them as Parkinson's. We have slow movement orders with no risk factors or decreased risk factors for vascular impairment. What about a patient who's slow moving with risk factors? We consider that could be possible vascular dementia. These are little tips to help get a diagnosis. Vascular dementia, we'd say, is slow moving with risk factors for vascular impairment. If they have movement disorders, slow movement disorders with no risk for vascular impairment, we consider it Parkinson's. And the goal is to get biomarkers, and the reason why we'd want to get biomarkers, and we're slowly but surely getting there, is we could test these and see what our levels are and see if we have lifestyle improvements through exercise, better diet, and see if there's improvement in the biomarkers. That is the goal. We're slowly surely getting there. Cognitive impairment, mini mental status exam less than 24 is 87% sensitive, 82% specific for dementia. Mild dementia or highly educated can have normal scores on that mini mental state exam, maybe scores of 27 in patients with college education. Let's go back to that real quick. There is the other tool, which is the Montreal Cognitive Assessment. This one is not copyrighted and can be used. This is the MoCA score. Dementia, gradual and progressive decline in cognitive function resulting in impaired social occupation functioning and leading to loss of independence. Impairment in at least 2. So impairment in at least 2 is cognitive function, impaired social or occupational functioning leading to loss of independence. So if somebody has a higher education or occupational advancement, there's going to be delay or reduced risk of onset. So once you're diagnosed with dementia, it reduces the lifespan. Your lifespan is usually 3 to 12 years post-diagnosis with longer duration associated with early onset diagnosis. So we got an early diagnosis of dementia. Differential diagnosis from normal aging, the loss of independence and daily functioning. Alzheimer's is the most common type, which is 60 to 80% of the cases. Advanced age is the number one risk factor. Every 5 years above 65, the prevalence of the disease doubles. So aging is the number one risk factor. Our continued discussion on dementia. Motor, gait, and cognition should be examined and is required by the annual wellness visit covered by Medicare. The MoCA, which is the Montreal Cognitive Assessment, is over 26 is considered normal. Alzheimer's average score is 16.2. Mild cognitive impairment is at 22.1. Remember, this is free. The MMSE is copyrighted. What tests you may want to consider are like a CBC, LFT, TSH, B12, ammonium levels, renal panels for creatinine bun. You want to review the medication list, make sure there's medications that are not going to cause impairment. Diphenhydramine can be one if they're taking this regularly. In high-risk patients, you want to consider syphilis, autoimmune workup if that's relevant per the patient's history. Once dementia is diagnosed, you want to confirm this with an MRI or CT done to evaluate for non-degenerative causes that could cause altered mentation. Continue discussion on dementia, Alzheimer's disease. There's vascular dementia. Frontal lobal dementia, we'll talk about each one. Dementia with Lewy bodies and Peyronie disease. All right, so Alzheimer's, there's mainly going to be beta amyloid plaques and neurofibrillary tangles versus inflammation. So this is the discussion. We'll kind of talk about Alzheimer's and how there's been some kind of discussion. Alzheimer's disease, early insidious, short-term memory loss, language deficits, and spatial disorientation, later personality changes. Vascular dementia is stepwise decline, early executive dysfunction, cerebral infarction. Frontal temporal dementia is early personality change, atrophy, disinhibition, and compulsive behavior. This would be frontal temporal dementia. Dementia with Lewy bodies, visual hallucinations, spontaneous Parkinsonism, meaning that it didn't happen gradually, fluctuating cognitive attention, alertness, REM sleep behavior disorder. We'll talk about this, how Puridol is contraindicated, donepezil is safer. Pyrene disease, behavioral changes with rapid progression, myoclonus and or seizures. Bremaprexol, this is for improved agitation in patients with Alzheimer's disease. So this was used in patients who had Alzheimer's disease who have aggressive behavior. And if it is an atypical antipsychotic, remember the other atypicals, antipsychotics in dementia can cause harm, including death, and have a black box warning. This is a placebo versus bremaprexil, 2 milligrams a day versus 3 milligrams a day. I'm really hoping this works because we could really use assistance in this in the hospitals and in homes and nursing homes. This was among 345 participants. Mean age was 74 years old. And the patients were randomized to placebo versus 2 and 3 milligrams of bremaprexil and had a significant reduction in agitation inventory scores compared to placebo from baseline in up to 12 weeks. The study completion rate was about 88% completed. In the treatment arm and 4% in placebo, discontinued because of adverse effects. So the discontinuation was about the same between the placebo and the treatment arm. Most adverse events were mild to moderate in severity. Headache was the most common in both, 7% in both treatment and placebo arms. So these patients had a great improvement. So this could be a life-saving drug for providers and nursing staff in our nursing homes, home care, and in the wards and ICUs. Other causes of dementia, multi-infarct dementia. CT scan shows hypodense areas of both white and gray matter without enhancement. Deficiency of thiamine, B1 thiamine or B12. Talked about this in Wernicke's. Hypothyroidism. Normal pressure hydrocephalus. Billy Joel was diagnosed with this. This normal pressure hydrocephalus, you have dementia, gait disturbance, urinary incontinence. CT scan shows a dilated ventricles. Treatment can be a ventral peritoneal shunt, draining that fluid out. Can you discuss on other causes of dementia? CNS infections, cryptococcus, syphilis, HIV, Crutchfield-Jacobs disease, which would show in the CSF, would show 14-3-3 protein, and EEG shows triphasic spikes. Caused by infectious prions, can be transmitted through corneal transplant and contaminated growth hormone. You know, growth hormone is now made synthetically. You don't see that much anymore. Can be rapidly progressive dementia, myoclonus, shaking. We talked about that, jerking. Focal cortical signs and rigidity. Diffuse weighted MRI is going to have hypointensities in the cortex, cauda, and putamen, thalamus. Brain biopsy is required for definitive diagnosis. Now remember, anything that's used in these, any instruments have to be thrown out. It's a very important thing because they can be spread. Frontal temporal dementia, dementia prominent with personality and behavior changes. So if somebody was super nice and quiet, their life analysis becomes loud, disrespectful, angry. This is a change. MRI is going to have prominent asymmetric focal lobe atrophy. Normal pressure hydrocephalus. Remember, Billy Joel was diagnosed with this. Urinary incontinence, ataxia, frequent falls, wide base gait, cognitive dysfunction, complaints of the feet being fixed to the floor. Treatment, as we discussed, is ventral peritoneal shunting. The pathophysiology remains incompletely understood, but current hypothesis indicates chronic disturbances by CSF dynamics in vascular changes leading to progressive white matter damage. Imaging features shows the ventricles are enlarged, disproportionate to the cerebral atrophy. You have effacement of the convex sulci and enlarged Sullivan fissures. The concept of disproportionately enlarged subarachnoid space, hydrocephalus, is now recognized as a key radiographic marker. Alzheimer's disease, most frequent cause of dementia, increased production, and we'll talk about this, of accumulation of beta amyloid peptide, which results in cerebral dysfunction leading to a deficiency of acetylcholine. Treatment, central acting cholinesterase inhibitors, best initial therapy, donepezil, rivastigmine, N-method D aspartate receptor antagonist, lamentidine, this is going to be second line. SSRI for depression and antipsychotic behavior of antipsychotics. We talked about how antipsychotics, the atypicals, can have a black box warning. Patients can have delusions and hallucinations. Clinical features, prominent loss of short-term memory, progressive impairment of activity of daily living, variety of neuropsychiatric symptoms and behavioral disturbances. CT will have cerebral atrophy with dilated ventricles and sulci. It could have non-enhancing paraventricular white matter lesions. All right, let's talk about allegations of fraud in Alzheimer's disease research. The amyloid hypothesis, remember amyloid, the beta-pleated sheets with the neurofibrillary tangles. Recent reports of fraud in one of the most major papers that have been cited. This is perplexing. We're not going to go through this. Basically, they use misinformation. And what happened is the paper in question reports of specific aggregation, the 14 beta amyloid molecules, and then this is the toxic culprit in Alzheimer's disease. But investigators were skeptical when they failed to reproduce this finding. So this paper that everybody has been citing, they've been failed to reproduce this finding. So what do we know about amyloid? Anti-amyloid therapies, they haven't really worked. Amyloid is necessary but not sufficient to cause of dementia and Alzheimer's disease. For example, amyloid is a novel foreign protein to the immune system, triggering immune responses. So what the basic question is that, is there an inflammatory process underneath all this, or is it just the amyloid itself? The reason why there's been a lot of questions is because we've had multiple anti-amyloid therapies, and they really haven't been effective in treating and curing Alzheimer's disease. What are we missing? Is this an inflammatory component? Now there's a question of that, is there a repeated exposure to a disease that is common in our system, maybe HSV, maybe EBV, maybe CMV, where our body keeps having an immune response, and this causes development of Alzheimer's. Maybe these plaques are developing from this. Remember, the scientific process is in action, uncovering fraud from data from 2006. Remember, hypothesis theory is never proven, truly proven, but only supported. So this is disheartening that this came up, and just think about the billions of dollars that have been allocated towards Alzheimer's research to specifically avoiding and removing and reducing the amyloid plaques, and then we give medications that have, and the patients really haven't gotten better. Is it because these plaques, once they form, basically the patient's brain is already cooked? There's still a lot of questions, and having fraud in the Alzheimer's research does not help us. Acetylcholinesterase inhibitors, contraindications, there's donepezil. You can have sick sinus syndrome. You want to avoid it in this because it can cause sinus block, left bundle branch blocked, uncontrolled asthma because the acetylcholinesterase inhibitor. Acute closure glaucoma can make it worse. Peptic ulcer disease can make it worse.